Okay, so this is just me re-recording the discrimination aspect of the sensory system. So discrimination is just the ability to differentiate 2 points in a small area. It's also a means of also being able to differentiate touch, deep pressure, or texture. Because sometimes, there are about two assessments I'm going to perform. The first assessment is actually having the patient close their eyes and just putting a random object in their hands and having them feel and to identify what objects they are. And then this is like done in both sides, so the patient is able to differentiate, and tell what objects he or she thinks it is. And the second way is the use of a caliper. So you know that the caliper has two ends. So you just put them together and just create 1 point or 2 points in the area, and have the patient differentiate if he or she felt 1 point or 2 point. And this is like done very randomly. It can be done in the fingers, it can be done on the legs, just to help differentiate. You can try, differentiating on both sides. Okay. So my patient, I can try, 1 point, and ask the patient, what does the patient feel? If the patient is able to tell me 1 point, yeah, that's good. And then I could try 2 points, try that different and different parts of the body to see how the patient is able to differentiate that. Okay. And then lastly, I'm going to talk about the deep tendon reflexes. Okay, deep tendon reflexes are they just is a neurological exam that's used to evaluate the nervous system. It also is a means to find out the homeostasis between the cerebral cortex and the spinal cord, and it also gives an info about the upper and lower motor neurons. Okay, so in the aspect of the upper arm, okay, so in this case, I don't have a reflex hammer, so I'm going to be using the head of my stethoscope. Okay, so the bicep muscle is actually mediated by the C5 and C6 nerve roots. So in this case, to initiate that bicep response, we're gonna strike at the acubital aspect of the arm, and then once we do that, we're just going to notice a contracture of the bicep muscle, and then a flexion of the forearm. And if we want to try on the lower leg, we can do that on the patella. Okay, because it's actually triggered by a knee jerk. So when that happens, the knee jerk is usually mediated by the L3 to L4 nerve roots. So how that's done, I'm just gonna have the patient, and this is while I do this, I'm just gonna distract the patient, so the patient relax and the patient doesn't really tense up or anything. So I could be maybe asking the patient about his family or hobbies and things like that. And so I'm just gonna go keep talking to the patient, and then I'm just gonna strike the patella, and you're gonna notice a knee jerk, push out, kick out, like a kick out, and that's, and that actually shows that, okay, that the nerve roots are actually functioning, and there's that that there's actually a reflex in this part of the this aspect of the nerves. Okay, and then we can do it on those on those nerve roots because of the transmission. And then we can try on both sides, and also on bilateral arms. When there is an absence of any knee jerk or any reflex response, is known as hyperreflexia. And then when there is like a hyperactive or repetitory movement, it's known as hyperreflex. Is also known as hyperreflexia. And then what I found, discovered from research, and I was told it could be disease process of one or two components of the two neurons in the reflex arc for there to be for there to be hyperreflexia. And in hyperreflexia, it's probably a lesion noted above the level of the spinal reflex pathway, probably an interruption between the cortical spinal aspects and other descending pathways. So those could lead to that. So but in that case, this ends my assessment for sensory system. Thank you.